Good afternoon and welcome to the ReCONNET webinar on relapsing polychondritis. I say, okay, we share the screen. My name is Oliver Sander. I'm a rheumatologist from Düsseldorf in Germany, and I'm member of the Relapsing Polychondritis disease group and of the working group on education and training in the ReCONNET network. And I'm quite glad to welcome Simona Rednic as a speaker of this webinar. She's professor and head of rheumatology unit at Cluj University in Romania and at the University Hospital. And she's also the disease coordinator for relapsing polychondritis in ReCONNET. We have decided to make a webinar on 10 questions in relapsing polychondritis, and therefore we asked our patient organizations to collect questions, and we got nearly 50 questions from 8 countries and several patients with relapsing polychondritis, and we grouped these questions to disease-specific diagnostics, therapy, clinical course, healthcare, and non-specific inflammatory aspects. And then we selected the 10 most relevant or interesting questions in our disease group, and we have tried to give a representation of all aspects of the disease with these 10 questions. For this webinar, we will have a recording and it will be published later on the ReCONNET's website and on the YouTube channel, so you have the possibility to review it and to see it or send it to your friends later. If you have questions during the webinar, use the questions and answer session in the Zoom black bar or use the chat, and we will discuss them at the end of the speak. And I will address the questions to the speaker, to Simona, at the end. So now, Simona, we will start.
Thank you, Oliver, and thank you to all of you that you are present. Good afternoon. Happy to talk about relapsing polychondritis, which is a rare disease, but it's a very interesting one, and we have to know and to make knowledge, to raise the knowledge about it. As Oliver said, we was selecting 10 questions. Definitely there were more, and there are many questions about this, but we selected 10 which we were find that are really interesting and trying to cover all the fields. One of the question was, which are the first signs of the disease? Maybe some of you remember that last year we organized another webinar about the red flags. So red flags are generally the first and the much more specific signs for a disease. Relapsing polychondritis is a highly variable disease. The manifestations are very variable, are also variable not only by the organ, but also by the severity and the duration. Sometimes they are very non-specific because there are so many signs. There is a significant delay in diagnosis. This disease is really not recognized, also because it's rare, but also because many general doctors do not know many things about it. But definitely the most and general, the first sign of the disease is ear chondritis. Is the most common feature, also as a first symptom, but also later in the disease. And if it is recognized, it permits an early diagnosis. Of course, fever or joint pain or ocular or cutaneous manifestation or audiovestibular can be also present. You can see here there is a table with the manifestation which can appear in relapsing polychondritis. In the first column, The first manifestation, the manifestation present as the first line at baseline, and also the cumulative rate of manifestation. And if you can see, auricular chondritis is the first one for both. So also as a first manifestation, almost half, 43% of the patient have as a first manifestation the ear chondritis, and also as a cumulative presence over disease course, almost 90% of the patient have this manifestation. Then it follows the arthritis, then the nasal chondritis, ocular manifestation, and things like that. If we are going a little bit further, you can see that there are manifestations like cardiovascular manifestation. We will talk a little bit later about them, which are never present at baseline, but they can develop on the course of the disease, and this is very important for following it. Going a little bit back for this first manifestation for the ear chondritis, generally can be also only one ear or both of them, frequently both. Up to 90% of the patient have in the course of the disease this ear chondritis. The duration of the pain, you can see it can be for hours and also for some days, but generally it's intermittent. And I remember you that the name of this disease is relapsing polychondritis. That means that the manifestations are intermittent, they are coming and going, and sometimes in the moment when patients arrive to the doctor, they do not have signs. Also, the onset of the ear pain can be or gradual or sudden, and the location of the pain can be in different part of the ear. Which is very important is generally the cartilage of the ear is inflamed, so typically the lobe of the ear is spared. And please remember to take pictures, because as I already said, the manifestation is intermittent. It can disappear till the moment in which you arrive to the doctor. So it's very important to have pictures. After several manifestations, the ear loses its normal morphology and it can be floppy. So here are some of my collection of ears from my patient with relapsing polychondritis. Please remember, you have to take pictures. This is very, very important for us. The second question which we will decide to answer, it's what about the risk of hearing loss? And this question was coming from Switzerland. Hearing loss is also significant in relapsing polychondritis. Almost half of the patient can have it. It's not a baseline manifestation, rare, it's inaugural. You can see it's only 7% in the beginning of the disease, but almost half of the patient can develop different degrees of hearing loss. So this is important because we have to take care and to look after these signs during the follow-up of our patients. There are two different mechanisms in which the hearing loss is appearing. One is a sensorineural. It's an inflammation of the vestibular structures or vasculitis. It's a medical emergency in a way. We have to recognize it very early and also treat it very early. And it's also another mechanism which is not so common, which is a conductive hearing loss due to auricular cartilage collapse, to the edema of the canal, to the closure of the external auditory meatus, or to otitis. So for this type of manifestation, we have to have ENT examination. We have to have a good relation with the ENT specialist. And this examination have to be due on regular basis to find it very early in the course of the disease and to treat it also early. Another question was about the cartilage. When our cartilage, of course, it's a disease which is with the cartilage, wears away, what is happening to our joints? Articular joints and articular manifestation are common in our patients. It's the second after the auricular cartilage involvement. So many patients have different degrees of joint involvement, often as the first disease manifestation. Some of the patient has only arthralgia, so only joint pain, but some of them have also really inflammation at the joints, which we call arthritis. When the parasternal joints are involved, like the sternoclavicular, you can see those the joints of the thorax, the sternoclavicular, the costochondral, the manubriosternal joints. This is very typical for relapsing polychondritis because this type of joints have a lot of cartilage, and of course this disease is about cartilage, but it's not frequent. Much more frequent are involved other joints, small or large, metacarpophalangeal joints from the hands or wrist or knee. We can have mono or oligoarticular involvement, 2 or 5 joints, or polyarticular. Generally is asymmetric, and often it's not very destructive, like in rheumatoid arthritis. The joint involvement is like the other involvement. Generally, it's acute. It's also intermittent. It's relapsing. And sometimes it resolves spontaneous or treating with NSAIDs or with steroids. And between those involvement, there are also symptomatical intervals. Of course, the vertebral involvement is very, very rare, and take care that these patients, or you are treated generally with steroids in the flare, and steroids could do other joint or bone involvement like osteoporosis or osteonecrosis. Another question was about the airway involvement, and of course, airway involvement, it's very important. We have a lot of cartilage at the level of laryngotracheobronchial tract, and this airway involvement may range from mild, sometimes discrete, but sometimes very severe and serious manifestation, and it can be a medical emergency. So when we have laryngeal involvement, which generally it's beginning with pain, it's acute, it can be intermittent or chronic, and it can present with or determine stenosis, and sometimes it's really an emergency. We need the tracheotomy. And if this type of involvement is the first manifestation, of course, also diagnosis, it's very difficult. If this manifestation appears in a patient which is known as having relapsing polychondritis, it's much more easy to deal with it. But as a first manifestation can be difficult. Also, sometimes the tracheobronchial involvement have also a poor prognosis. It's the major cause of morbidity and mortality. It can appear because of the fixed or dynamic narrowing of and stenosis of the tracheobronchial branches, and sometimes it's very complicated. Generally, this type of involvement requires aggressive and early treatment with glucocorticoids, with immunosuppressant, and also with biologics. We will come back to questions about the treatment. Sometimes airway intervention is required, like balloon dilatation, stent placement, sometimes tracheotomy, or combination of the above mentioned techniques. And as I begin with, this type of involvement is the most serious one. Another question was about the heart. When we are thinking to relapsing polychondritis, we are not thinking on it like to a cardiovascular involvement, but cardiovascular involvement can happen in about 10% of relapsing polychondritis patients. Generally, it's not in the beginning. It's very rare at diagnosis, but it can appear in the first 2 years. This is very important because we have to active search for it with echocardiography and with close relation with the cardiologist. The most frequent is the isolated aortic regurgitation. As I told you, in the first 2 years after the diagnosis, and we need to do echocardiography periodic. Other manifestation like mitral valve involvement or aortitis or aortic aneurysm or aortic ectasia are much more rare, but we have to, the doctors have to have in mind that some patients can develop also those type of manifestation. Again, having this type of localization, it can go to a very different evolution, because sometimes it goes to resolution, sometimes to improvement or stabilization, and sometimes to deterioration, recurrence, and need to other intervention, and also to surgical intervention. Patients which have a very bad evolution are patients which have aortic involvement or high inflammatory markers like ESR. And also this type of involvement also need an aggressive treatment, so timely immunosuppressive therapy, steroid. We have to active search for it, active follow-up, and to have a good relation with a cardiologist. We had a question about the specific diagnostic test, and I have to admit that there are no specific laboratory tests for diagnosis relapsing polychondritis. The diagnosis is based on clinical data, reflecting, of course, the involvement. We talk about it in different cartilages, and to the presence of inflammation. It's also important to rule out other diseases, because relapsing polychondritis can come together with other diseases. And sometimes some investigations are being done to see whether this disease accompanies other diseases, such as lupus or rheumatoid arthritis or VEXAS or vasculitis. The combination with vasculitis of relapsing polychondritis is common, and also with Behçet disease. Examination have to be performed upon diagnosis and during the follow-up, and also have to assess the organ involvement we already talk about. But there are no specific tests. we had to do. In a way, related with this disease is another disease if we need to do genetic testing for relapsing polychondritis. And again, the answer is no. There is no need for genetic testing in general. It's an autoimmune disease, there is a genetic risk, but it's very vague and general, and we do not need to test it. And there is not one genetic predisposition clear. Also, the familiar cases of relapsing polychondritis are very rare. But very recently, 2 years ago, was described a new disease, which is called VEXAS. There were male patients, generally over 45, with relapsing polychondritis, many of them, and features of myelodysplastic syndrome. And this VEXAS, it is caused by a somatic mutation in the UBA1 gene. If your doctor is suspecting such a disease, UBA1 gene can be tested. Can relapsing polychondritis be misdiagnosis for another disease? Yes, generally, for us, the rheumatologist, sometimes the diagnosis is not so easy and not so straight. It's not always obvious, and sometimes when patients reach to us, the delay is already happening. Of course, sometimes they are coming to the rheumatologist in the moment when chondritis had already disappeared. I come back to the idea that we need photos, not only for the ears, but also for the nose, or also for some cutaneous manifestation. Of course, the list of differential diagnosis is large, not only for the ear chondritis, but also for other types of involvement like general manifestation or arthritis. And there are situations in which the diagnosis is not so straightforward. Also, things are a little bit more complicated because relapsing polychondritis is frequent overlapping with other systemic diseases like vasculitis or Behçet disease. So Behçet with relapsing polychondritis it's called the magic syndrome, or with other rheumatoid diseases like rheumatoid arthritis or connective tissue diseases like lupus. So when this coexistence is happening, the diagnosis can be a little bit much more difficult, and the way of treat it also have to be nuanced. What should people with relapsing polychondritis expect in evolution? This is also a difficult question, not only for relapsing polychondritis, but for all connective tissue diseases, because there are very different pathways and way of evolution. Generally, the outcome is not uniform. And very difficult to predict. Generally, it's a long-standing disease, which is evolving with relapsing and period of remission. Sometimes those periods of remission can be very long. If we treat it correct, and the patient are followed in a proper way, yes, the remission can be long. There are also patients which have a chronic course and sometimes develop respiratory issue or sometimes complication of this disease, including other associations like hematologic malignancy or VEXAS. But overall, the recent studies showed an improved outcome, also because of the disease is much more better and earlier recognized. And also a little bit regarding or similar with the same question was a question about do people with relapsing polychondritis reach remission? Again, there are several reports of remission in relapsing polychondritis, but we generally can talk about very long periods of remission between flares. The survival rate of relapsing polychondritis has increased remarkable because we recognize it early and treat it promptly, and we also using new therapies. Only 1/5 of the patient achieve complete remission in the first 6 months of therapy. And moreover, we have to look to the relapsing polychondritis like an unpredictable disease, and the recurrence and the flares are still a significant concern. The ninth question is, of course, about steroids. Steroids are great, is saying one of our patients, to help during the day. But I know when they are still working, is there anything we could use at night as the symptoms appear? Steroids, of course, are very effective in acute flares of relapsing polychondritis. There are still the anchor drugs, and we are using them. But of course, all of you know that steroids should be reduced to minimal doses after the flare control, because steroids have many, many side effects. And again, it's a known thing about this. We can use other drugs like methotrexate or other immunosuppressor or even biologics, which could be added as a steroid-sparing agents and can lower the use of steroids. Sometimes the steroid dose could be divided in 2/3 in the morning, maybe 1/3 at noon. Generally, we do not like to have steroids in the evening because insomnia and other sleep problems. And sometimes there are steroids which have a longer half-life, which could be used. But the idea is that we have to stop as early as possible the steroids and use other drugs. The last question is about the most recent treatment options. If there are biologic medication which we can use to prevent progression, and which type of side effects do they have? Of course, treatment of relapsing polychondritis differs a lot from a patient to another, because being so variable as a disease, of course, we will treat different a patient with joint pain from a patient with cardiovascular or upper A involvement. So treatment is based always upon the type of the organ involvement and, of course, on the severity of involvement. And generally, we are using, and we are extension this indication from other diseases which we know better, like vasculitis or rheumatoid arthritis. Relapsing polychondritis being such a rare disease, we do not have a clear drug. We do not have randomized control trials for relapsing polychondritis. We do not have a specific target or a specific drug to use. As I already told you, of course, we are using steroids for the flare. We are using a lot also conventional immunosuppressive, from methotrexate to azathioprine to leflunomide to cyclosporin, mycophenolate, mofetyl, cyclophosphamide, in some condition Dapsona, and also biologics, generally the TNF antagonist, but also tocilizumab, rituximab, ABA, and anakinra. But of course, the evidence of biologic is limited to small cases, to small case series, to some retrospective reports and some data from the registry. And there is no best principle or a best drug to use, but the most experience is on TNF inhibitors. And you can see here is an article coming from the French National Multicenter study with 41 patients with relapsing polychondritis exposed to 105 biologics, the majority of them, more than 60, being TNF inhibitors. The overall response rate was good, so 62%. A complete response rate was around 20%, and the reducing of the corticosteroids was possible in some of the cases, but was again very variable. And approaching to the end, not really as a 11 question, I have to answer to that one. Is there a specific reference or paper which we can recommend to present to our numerous doctors or GPs which have never heard about relapsing polychondritis, but they have to take care after us? And yes, there are several articles. There is the French practical guidelines. There are also access to some articles on the ERN website. There are also the webinars you can find on the ERN website. Webinars are also for patients, but also for doctors or for general physician. All of them are open access, so you can find them. This is the page of ReCONNET on relapsing polychondritis with the two disease coordinators, me and Laurent Tagneau from Strasbourg, France, and the two EPAGs. And another question which I have to answer at the end is, which type of doctor should see a relapsing polychondritis patient? Generally, rheumatologists, which are used to see rare diseases, are the doctors which are looking after this disease. But of course, sometimes we need the help from the otorhinolaryngologist, from the pulmonologist, from the ophthalmologist or cardiologist, and also other physicians. It's a multidisciplinary team. It's important that to have a dedicated center with doctors which have a little bit of experience in this very rare disease. And the advantage in this setting is that some potential types of involvement, the airway or the cardiovascular involvement, may be actively searched and treated early, effectively, and aggressive. So thank you. I'm waiting for the questions, and I want to remember you that relapsing polychondritis is not only about ears and noses. Thank you. And I wish you a very and a beautiful spring.
Thank you, Simona. It was a nice overview and a good answer to the most important questions of our patients. So there's one question from Maurizio, who considers the clinical characteristic of relapsing polychondritis that this syndrome might be considered as an autoinflammatory syndrome because there is no clear marker and less specific antibodies, and this probably relapsing nature with with few days of acute symptoms.
Yes, that's true. Maybe it's a fair comment because this disease is much more close to the autoinflammatory diseases with very significant general manifestation, intermittent apparition, and long periods of remission. Yes, between flares, and it looks like the autoinflammatory diseases. Yes, but I do not think that we have a clear idea about this. It's considered a connective tissue disease with autoimmune manifestation, not autoinflammatory.
I think it's both is possible, as we see from granulomatosis, and the best model for the autoinflammation is the Vexer syndrome, which I think is strictly autoinflammation. So we have a question from Carlos Roman Castieta, who first says thanks a lot for this, and it's a question on kidney involvement. How frequent is it? The person was diagnosed with mesangial nephropathy, with IgM mesangial nephropathy, probably related to relapsing polychondritis.
In pure relapsing polychondritis, renal involvement is possible but rare. But as I think it's around 5% or something like this. But the most important thing is I was already speaking about the overlap with vasculitis, and having a renal involvement have to take in account the idea of the association or of overlap with a vasculitis. So it's not mandatory, but it can be.
Yes, I think it's also important to test the anchors again if you have this, yes. Because sometimes you have an anchor negative start of granulomatosis, and then you have nephritis, and then it's positive. So if it was once excluded, you should exclude it again when you have the nephritis.
Of course, yeah. Anchor are important also, yes.
And then we have an anonymous question. Is a biopsy necessary for diagnosis?
No, it's not mandatory. If we are speaking about clear ear chondritis, it's not mandatory. Only if there are suspicions. I was showing you some possible differential diagnosis of vasculitis, of other syndromes, or toxic involvement of the ear. And if there are such suspicions, maybe. But if the manifestation is clear, and also if the manifestation is coming together with other manifestation which suggest the disease, it's not mandatory. Sometimes it's helpful if something is not typical, but not mandatory.
Okay. So at the moment, we don't have any new questions. So we perhaps wait some. Oh, yes, there's a new question coming in. Okay, there are some other questions. What signs distinguish the magic diagnosis?
The magic syndrome is overlap between relapsing polychondritis, signs of relapsing polychondritis, and signs of Behçet disease, which are coming with bipolar aphthous, or much important ocular involvement. And there are manifestations which are typical also for relapsing polychondritis and also for Behçet. That's the magic.
Then there's another anonymous question. Can you speak about presentation in children? Does it differ from adult?
I must admit I've never saw this disease in children. I do not have experience. I do not know if maybe it is present, but I never saw a young, very young patients, and also not a child. Maybe
Yeah.
you.
No. I have never heard of a case in child. I think it's some case surprising because we have many autoinflammation in children, but probably it's another type of autoinflammation in children. So I have never heard of a case in a child. No. And then there's a further question: would the differential diagnosis be different in a pediatric patient?
No, again, I do not have experience. It's not a diagnosis frequent in pediatric patients. Do not think it's.
Probably other causes for red ears, like.
Yeah, but other,
Yes, not the chondritis or
not
an infection with chondritis or something like that. Repeated infection with streptococcus or so.
Erysipelas or something like this. I saw a question about intervertebral discs.
Yes, from
Do they
Maurizio.
crash? I didn't have such an experience, and I can't remember to read about this. So axial involvement is not described. I do not know about it.
So, okay, we have one participant who has an involvement since his 13th year of age. So it started at 13 and he's now 30, he or she is now 35, but probably it was as a young grown up and not as a child. So we see, I think, lupus and GPA also in people with 15, 14 when they are, but not as small childs. So probably if you are 16, it might be the same like in adults.
In our cohort, we do not have children or beginning at an early age. So I do not have experience, but.
There's another participant who has it from the age of 11. So perhaps they could write us with their initial symptoms. We could learn something and bring it to the discussion in the group, because when we never seen it, and now we have two who started as a child. I think it's interesting for more knowledge on the child manifestation. So you could help us, write us an email if you want, share your disease, the course of your disease, so we could discuss it and learn from it. Thank you for the.
Of course, we can ask also our rheumopediatrician about their experience.
There's a question on the best diet to help with relapsing polychondritis.
The question about diet is always appearing. There is not a clear diet for autoimmune diseases in general. Of course, an equilibrated diet, not low fat, but there is not a clear relation between diet and relapsing polychondritis.
Okay, there is a question. My father was diagnosed with relapsing polychondritis a few years. He started with inflammations in the ears, joints, and in his eyes. He's showing signs of erythromelalgia. Does that mean that RP is advancing quickly?
No. So it depends. Erythromelalgia is not. It's not a sign of advancing. So it can be one of the manifestation, but no, it's not. But of course, he have to be looked not only for ears, joints, and eyes, but also for cardiovascular manifestation or other manifestation. Yes.
Okay.
So Lisa, which is our EPAG, is writing that they have in the relapsing polychondritis group in UK three children under 10 diagnosed with relapsing polychondritis. Thank you, Lisa. Of course, it's important. We have to discuss, and also we discuss with the rheumopediatrician in the group about this.
And the one who reported to be manifested as a young child has another person in the family who started as an adult, so there might be some genetic background too.
Yeah.
So we have many thanks. And the
Okay.
question, do you ever see tricuspid valve regurgitation in relapsing polychondritis?
I do not understand what?
Of the tricuspid valve, regurgitation, like a tricuspid insufficiency.
No, I'd never seen. It's also not described. The most common manifestation is aortic regurgitation, and much more rare the mitral involvement. Maybe tricuspid is also possible, but I think it's very, very rare and very uncommon.
I think it's so common in the common population that it is not more often than in the common population in people with relapsing polychondritis. So when you intensively make echocardiography, you see it sometimes, and perhaps with lung disease. So if you have a severe lung disease, you might have it from secondary right heart failure due to the lung disease, probably, but not directly.
Of course.
Okay, there's another question. Is there any other recommendation a patient can do naturally outside of medication to help with the disease?
So, yes, there are generally the general recommendation for our rheumatic patient. They have to try to remain active. They have to try to exercise, of course, in a medium manner and in the way they still can, not forced, but to remain active. They have to take care to the infection, to vaccinate when needed. I think things like that.
Yes, it would be my recommendation too. To build up a network of specialists and friends who support you. This is my first time joining this type of webinars. Will you be hosting any more in the future?
Yes, yes, will be. We have webinars. So generally in ReCONNET, there are regularly webinars, and also we are having for the relapsing polychondritis group webinars, 2 or 3 a year. So you also are able to find our past webinars on the ReCONNET page. So yeah, it's an action which we are doing regularly.
And there will be at least one new webinar every year for patients and at least one every year for healthcare professionals on relapsing polychondritis, and in addition to other items like diet or physiotherapy or something like that.
Yeah.
So I appreciate you sharing your experiences and advice as expert on relapsing polychondritis are also very rare. Having a long-term outlook and consideration of alternative treatments are very helpful. Thank you very much. I think this is more repeats than a question. And there's another remark, which is perfect. Thank you. So from our experience, and I'm in a commission on alternative treatment for rheumatic diseases on the German Society of Rheumatology, and we did a lot of work to look at the literature for that, and many people think that it would be good to have alternative treatment like natural treatment, diet, and so, but the scientific evidence is very, very, very low, and the scientific grade of the publications on that is usually very, very low. Only few patients, only bad results, and terrible publications in overall, and only even in those things which are very common, you have nearly no data that there's anything helping except the people who sell the things.
Yeah.
So, and it would be hard to have any data on relapsing polychondritis because you have a spontaneously remitting disease, and if it's getting better, it must not be the drug or the food you take. It might be the spontaneous cause, and it's really hard to have data on alternative treatments in that disease in addition. Okay, so I don't see any more questions, and Mauricio does not have any more comments. I think we are good in time, and thank you all for discussion. Simona, many, many thanks for your good talk, and all the participants for the interesting questions and remarks. And I think we have some work to do on the children. We hopefully get some information on that, and so we learned too from you.
Bye.